Good afternoon to everyone present here with us today. This is Shreyan, your moderator from IGCP. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by your keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Banshi Sahu. Sir is MD Internal Medicine, FACE, PhD, RSSDI, Chief Diabetologist and Chairman of Diabetes Care and Hormone Clinic, DiCare, Ahmedabad, Chair-elect IDF, Southeast Asia. With the help of Sir and his wonderful insight, we'll be taking a close look on today's topic, which is managing type 2 diabetes in 2024. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Thank you. First of all, thanks IJCP for giving me this wonderful opportunity on this platform. I'm also thanking all the delegates and participants who are joining today afternoon. And what I am going to talk is managing diabetes in 2024. I have nothing to declare, no financial disclosure for this particular talk. In next 30 minutes, I'll be talking that what we can do in 2024, what things have changed the way we were treating our diabetes in last 3 decades. As I am practicing since last 25, 26 years with my MD and MBBS days, it's almost like I have experience of treating diabetes of last 3 decades. Now, this is very famous slide, which has been used in Kelly West Award lecture. In Diabetes Care 2016, this was published also. That in type 2 diabetes, actually why we are winning the battle but losing the war. The point was they were trying to say that so many newer things had come in the market. Actually, we are trying to treat diabetes from pathophysiological point of view. We are winning the battle, but still 2/3 of our diabetic patients are not under good control, and that is the meaning of losing the war. So it means we are one side, there is a lot of research is happening, a lot of newer molecules are coming, a lot of new papers are coming, and we all know that they are going to help our patients for improving their life. It is going to improve their diabetes care. At the same time, it is going to prevent their complication also. But still, most of diabetic patients, they are not under good control. And this is true for India because last 25 years, in my practice, I am seeing that a lot of CMEs, a lot of new educational activities, which we keep on doing. So many newer molecules have come in India, and still our 2/3 of our diabetic patients are not under good control. So what we should do in 2024? So I'll be talking an introduction with a case study. Then we will be talking something about the management, lifestyle talk, clinical evidence of CV and renal outcome, guidelines recommendation, a treatment algorithm, and then I will, the same case which we have started with that, we will conclude. Before that, we will final management for that case study, and then I will conclude my talk. This is what I'm going to do in next 25 minutes. This is very recent data, which has been published in 2023. It's talking about in India, we have 101 million people with diabetes. We have pre-diabetic population, 136. We have dysglycemia is 236 million people. So you can understand that at present in India, if we just put the number, because this was calculated as per when we were 110 crores. So you can say that 20% of them, the population is actually dysglycemic. And if I just put the adult population, which is above the age of 20, it will be like every third person in India will be having dysglycemia. The blood pressure range is again very high. So we have, other than dysglycemia, multiple cardiovascular risk factor for them, like hypertension. We have generalized obesity. We have abdominal obesity. We have hypercholesterolemia, and we have high LDL cholesterol too. As I told you, the type 2 diabetes is remain always a challenge. This is a paper of 2007, which is talking about 80.3% of the patients are not under good control. We have our unique problem because we develop diabetes early. We develop with lower BMI. We have higher cardiovascular risk complication. We have with a poor beta cell function, and we get diabetes also early, as I told you. But the same data in after 7 years, in 2014, still 70% of our diabetic patients having HbA1c of more than 7. So, I mean, even after 7 years in 2007, 2014, nothing has been changed. This is a data of 2020, which is again talking that more than almost 70% of the patients, or it is 78% of the patient having HbA1c is more than 7. So it means there is nothing has been changed. I had shown you three data. I mean, we have the data of 1998, 2005 also, and probably again in 2023 or 2024 data will be published also soon, that what is the status of diabetes control in our country. We have a lot of therapeutic advances, as I told you, from metformin, sulfonylurea, insulin. When we were the resident, these were the three molecules. Even after so many years of newer molecules, public hospitals are still having metformin, sulfonylurea, insulin. But over a period of time, then alpha glucosidase inhibitor, and then basal insulin, and glinides, and GLP analog, DPP4 inhibitor, all things have come in the market. But still, as I told you, nothing has been changed as far as glucose control is concerned. But yes, these newer molecules had shown very promising results: less hypoglycemia, more weight loss, or no weight gain at least. And there was it in clinical trial, it had shown that by using them, these molecules have shown they reduce the complication. Also, the SGLT2 trial, SGLT2 inhibitor, and GLP-1 had actually completely changed the way we are treating our diabetic patient. CV outcome trial and renal trials have come in last 15 years. UK PDS has explained it very nicely that intensive control of a diabetes is going to reduce the complications. I mean, if you have a very intensive control, you will find less and less complication, that we know from type 2 diabetes. But few new things which we learned in last 15 years. One is there are multiple pathophysiological defects in type 2 diabetes. When I passed out, we were understanding that diabetes is a insulin resistance followed by beta cell failure. But then we realized, no, there are multiple pathophysiological defects. Then we understood that diabetes is no more a progressive disease. Rather, it can be reversed, because this is a very interesting paper. In our last 15, 20 years, we were understanding this. Yes, it's a progressive disease, but yes, the data is shown in 2017, 18 that yes, it can be reversed also. Complications in diabetes can be prevented irrespective of duration of diabetes. In 2007-8, the paper was there that a patient with a 10, 15 years of diabetes, if you intensively control diabetes, nothing is going to give the benefit. Accord trial had shown that way. But later on, with the EMPA-REG CV outcome trial, they had shown that even the patients who have complication or multiple risk factor for the diabetes complication, still it can be prevented. The further prevention is possible. Type 2 diabetes is not one disease. It has got subtypes. I mean, a type 2 diabetes is not just a type 2 diabetes. It's a severe insulin deficient, severe insulin resistance, obesity, and age-related diabetes. CV outcome trial had proved that even with a longer duration of diabetes, the therapies are there to prevent the cardiac and renal problems. We have moved from A1C to time in range. The time had come that we were chasing all the time A1C. That is that a retrospective control we were seeing from A1C, and prospectively we were thinking that by changing the therapy, you will achieve this A1C. And in between, we will not know anything about the hypoglycemia. That has been completely changed by concept of time in range, putting them on a continuous glucose monitoring. We also understand that treatment of diabetes is not costly, but it is very costly to treat complications. The use of technology in diabetes will improve quality of life, definitely. And finally, what are the things which are most important for a diabetic patient? I think this is in 2024. We must again tell our patient that it's education, education, education. It is monitoring, monitoring, and monitoring, and a regular follow-up with the doctors, with your healthcare professional is must. These are the things which I learned in last 10, 15 years of my diabetes practice. As we know that diabetes is a continuum of type 2 diabetes. A patient with a diabetes develops all those complications, but yes, a early intensive therapy gives them a legacy effect. A UK PDS has talked that the same patient, if you have just treating at this point of time with aggressively, probably you will have less and less complication. But a patient who is not having a good early glycemic control, as what UK PDS has talked, it also gives you bad glycemic legacy. So the patients who are not aggressively controlled in an early course of diabetes, they have a bad glycemic legacy. So whatever best you do, after 10 or 15 years of a bad glycemic legacy, they are going to have some or other complication in their life. So that is what we have to understand. This is an early and aggressive control, which is very, very important, because it is very difficult, or it takes very long time to undo a bad legacy. So someone who is already having a bad glycemic legacy, if you try to best of the best way by which you want to control the diabetes, still the legacy to go for a bad legacy, to go undo bad legacy, is very, very difficult. This is what VNDT trial had shown, this paper in 2015. This is what a very interesting paper, and I always love that. Yes, we can change the natural history of type 2 diabetes. Completely we can change from the time of diagnosis, from intensive control, from the long-term complication point of view, giving them a medication which can reduce the weight, and their lifestyle will help them for also, even it can be reversed also. So what type of diabetes, so precisely we can do, and we can really change the natural history of type 2 diabetes. Now let me come to a case which is a very garden variety of type 2 diabetic patients, which we see in our clinical practice. A 54-year-old male school teacher with history of type 2 diabetes since 5 years and is obese. Physical parameter with a 29 BMI, others are fine. Lab is showing A1C of 8.4 with cholesterol which is higher. Patient is already on glimepiride and metformin. Now, this is a routine variety of diabetic patients which we see who are on sulfonylurea metformin, a patient with A1C of 8.4. Now, the physician or a doctor who was treating, he thought that yes, it is glimepiride 1 milligram. Let me put on glimepiride 1 milligram along with metformin with voglibose. So patient is on a one tablet only, glimepiride, metformin, and voglibose. Patient was asked to take this. So from 1 milligram, it has increased to 3. Metformin from 1,000, it had become 1,500, and voglibose, and plus lifestyle modification. Patient was asked to come back and check the regular monitoring. And this is what the patient's sugar was absolutely well controlled. The treatment goal was HbA1c to get less than 7. Patient was happy because patient sugar came down. Doctor was happy because his treatment is improving sugar control of his patient. So doctor is happy because he had used the best of the best molecule as per his knowledge. He had tried to get a good control of diabetes, no hypoglycemia. Patient was happy, doctor was happy, and sugar was well controlled. But what is the treatment goal? Yes, one goal is A1C. A1C should be less than 7. That's fine. Weight loss, mainly visceral. No weight loss was being done by the medication which is being given. No hypoglycemia. Still, there was no hypoglycemia, but he is at the risk of developing hypoglycemia. What about his CV hepatorenal protection? There is no medication which has been given which can have CV protection or a kidney protection for this particular patient. What about the comorbidity? We had not treated lipids. The blood pressure was also this high. Obesity and even thyroid also have not been checked. What about the foot care? Not been asked. A 54-year. More important is the sexual health, vaccination, the dental care, and patient is not been asked for a very regular follow-up and screening of complications. So physician was happy that he has treated the diabetic patient, but actually he should have done all those things, but he has not done, and that is what we should do in 2024. This is a very nice paper by one of my friend, Dr. Sanjeev Phatak, and myself and Dharmender Panchal. We have written the Blue Index, a comprehensive diabetes assessment score, just to explain the patient in a very easy way that you have to control A1C, blood pressure, cholesterol, diet, exercise, follow-up, general health, habits, infection prevention, and jeopardy of diabetes management. So whatever the best medication which you are writing, still patient may have side effect of that. So that is also not good. The general health of the patient is very important. Habits, we have to talk about the patient to the habits of this also. So this is in a comprehensive, this Blue Health Index score, which we give to all our patients, asking our educator to tick mark all these things, that what is under control and what is not under good control. So a doctor can spend more time to teach or educate about that particular thing. So his A1C may be very well controlled, but he's not being followed up. His A1C may be very well controlled, but he's not been for infection prevention. Nobody had talked to. He may be having very good A1C, but he's not been asked for smoking cessation or tobacco to be stopped. So these are very important points which we discuss with the patients by giving this blue index health score. We know some of the clinical trials had completely changed the way we are treating diabetes. Yes, we know that DCCT and UKPDS first time uh, had shown the importance of a good or tight glycemic control. But then the story had come with the rosiglitazone. How you treat diabetes, that is also very important. By giving the patient a glitazone was actually increasing MI and death. So that's the reason the patient is to be treated intensively, what UKPDS had shown, but not by any drug. The drugs may be also responsible. Then Accord had shown that a patient with a 10, 15, 20 years of a diabetes, there is a risk of increasing hypoglycemia. So these patients, a tight glycemic control may not give any benefit. But steno 2, ABC control along with the smoking cessation probably had given the benefit because UKPDS has thought there is no cardiovascular benefit, but steno 2 had shown no. If you just try to control only A1C, but along with that, if other risk factor, lifestyle modification, along with blood pressure and cholesterol, probably it also decreases the cardiovascular mortality. And then cardiovascular outcome trial, a dedicated trial of some of these molecules had shown that if instead of using anything, you use some specific molecules, they are going to change the complete. Even somebody have a complications or already cardiovascular disease, they decrease the hospitalization for heart failure and decreasing the cardiovascular mortality too. These are the older drugs which were available to us, and we had shown this paper which is talking about that all these drugs, nothing going to change the CV event. So I mean the AS, Tosca, IT, Advance, Accord, VADT, Devote, none of these molecules which are used in these clinical trial had shown any benefit as far as positive effects on major CV event. And then these many CV outcome trial, which is talking about these are the molecules, EMPA, KENA, they are all shown benefit or decreasing the hospitalization for heart failure and stress renal disease as well as cardiovascular disease mortality. Simultaneously, DPP-4 had also come, but DPP-4 was neutral. Some of the molecules had shown allogliptin and saxagliptin. There's an increase in hospitalization for heart failure, but CETA and linagliptin had shown neutral. That's the benefit of that. The CVOT of SGLT2 inhibitor had shown decrease in hospitalization for heart failure, CV death, and MACE, and these all four trials had almost similar type of data. GLP-1 had also shown, so it's a liraglutide, semaglutide, exenatide long-acting or elbuglutide, they all had, even the dulaglutide, and then the molecules like semaglutide, they all had shown the benefit as far as cardiovascular benefits are concerned. So ADA in 2024, they have recommended very specifically C for comorbidity, ASCVD and renal failure. Use the molecule which can have a positive benefit of it. The patients who have already CKD and heart failure patient first choice with SGLT2, then GLP-1 can be added. CKD patient, if severe issues is there, you can think of still putting the patient on GLP-1, otherwise SGLT2 in early course of renal failure because it helps for that also. The other management is weight. That is very, very important. So weight management, use the molecule like injectable semaglutide, liraglutide, which will help because weight reduction itself will help for these patients for decreasing cardiovascular mortality. Similar way, the hypoglycemia risk also can be significantly reduced with the patients who are using GLP-1 or SGLT2. This is RSSDI clinical practice guideline, which we are talking our patient, the same patient, you have to do the CV risk assessment. What you have to do, ED history, get CT coronary calcium score, GLP-1, SGLT2, and metformin is the choice. AGP for glycemic variability and glycemic pattern, we can do. So because 8.5, we wanted to know that when to add AGI or not to add. Is there going to give any benefit? Diet and exercise. Lipids and home blood pressure monitoring. The lipids are very important. 117, we have to keep it less than 70. Sleep study, obese person. We forget in 2024, you can't forget that. Yes, patient requires sleep study. Food and dental care, regular health follow-up plan with self-management education, and can we think of reversal in this case, at least in all stages? So actually, reversal is possible at any stage of a diabetes because diabetes progression means one side from normal glucose to pre-diabetes to clinical diabetes to diabetes complication at any given point of time. If you can reverse the flow, actually it is reversal of diabetes. diabetes. So we had proposed a journey of diabetes reversal, control, reversal stage 1, 2, and 3. And then finally, we talk of cure for diabetes. These are the 5 class of drugs which we all know. Insulin provider, other than insulin, sulfonylurea unites the increase directly insulin. Insulin enhancer is GLP-1 analog and DPP-4 inhibitor. Glucose excreter are SGLT2 inhibitor. Glucose restrictor are alpha glucosidase inhibitor. And insulin sensitizer, which is metformin and glitazone. This is one case which I want to discuss. This is a patient who had come to us with 2 consultations with other 2 doctors, and he was not ready for insulin. His HbA1c was 9.5. Patient, we asked that yes, you should be on insulin. You are already on triple drug, glimepiride, metformin, and vildagliptin. Patient was not ready, so we put the patient on AZP. After 5 days, patient sugar all was high. So we explained the patient, let us put you on GLP-1. The GLP-1 and SGLT2, we stopped DPP-4 and we continue with the glimepiride, but we reduced dose from 4 milligram to 2 milligram. But we ask the patient every alternate day, probably your sugar may go down because we are adding SGLT2 and GLP-1 both. I don't know how much you will able to eat. So please call me every alternate day. And every alternate day from 2 milligram, we started 1 milligram here and 0.5 milligram. So within 6 days, actually, we had decreased from 4 to 2, 2 to 1, 1 to 0.5. And this is, to our surprise, last 4 days report. You can see that patient absolutely well controlled with a HbA1c. If you expected result or GMI, you will find it will be less than 6. But the patient who is to go as per the guideline to a for insulin, while we had completely changed the therapy of this particular patient. So managing type 2 diabetes is now not only just sugar control, minimizing the hypoglycemia, and use the molecule which have proven CV efficacy as far as cardiovascular death is concerned, and can be used in wide variety of comorbidities. So don't restrict your therapy in such a way that these are the so many contraindication of use. Rather than use more of an indication should be there. Continuous glucose monitoring, last few slides on the CGM, as though that DCCT trial in 83 had shown that patient can keep tight glycemic control, but hypoglycemia is a major risk factor, and they develop so many patients, like 62 per 1,000 patients, 1,000 patient years, while after putting the patient on CGM in 2008, drastically changed as far as hypoglycemia is concerned. And that changed in 2016 by putting the patient on an insulin pump. And here you can see on an insulin pump patient is how many times bolus has been taken. I mean, one just cannot think of every 15 minutes, 30 minutes, there's a bolus dose going on. That is what the automation is. And patient is keeping his sugar in a tight range, time in range, but most of the time even in tight range also. To conclude my talk, patient with type 2 diabetes mellitus suffers substantial morbidity and mortality from cardiovascular disease and renal disease. Many intervention studies in setting of type 2 diabetes, reduction in the management of diverse risk factor have translated into tangible benefits on hard endpoints. From a therapeutic viewpoint, it's time to try to educate both magnitude and variability of CV risk factor. SGLT2 inhibitors, CV and renal outcome make this class a great addition of type 2 diabetes management. With heart failure and the GLP-1 class, because an improvement of the quality of care, the attainment of their targets seem to be the best strategy to reach the goal. Thank you. Thank you very much.
Thank you so much, sir, for your wonderful presentation. So we do have some question if you like to take that up.
Tell me.
Yeah. So, sir, the first question is what novel pharmacologies, agent, and treatment modalities have emerged in the past year for managing type 2 diabetes, and how do they compare to the existing
So it's a
therapies?
GLP-1 analog, the tirzepatide dual GLP-1, GIP-1, which had come. It has got a significant weight loss with a very good control of diabetes, and probably a triple agonist will also come in near future. And the monitoring device, that's most important thing, because that gives you the education and motivation both to the doctor and patient.
So the next question is what are the current recommendations for cardiovascular risk assessment and management in the patient with type 2 diabetes, including the use of newer anti-diabetic agent with proven cardiovascular
CV risk
benefit?
factor the same that we know. There is nothing like any new CV risk factor had come. Like smoking, tobacco, these are more common in our India, lipoproteins, lipids, dyslipidemia. And the medication which we have to treat, which I had given you, the SGLT2 and GLP-1 analog are a preferred choice with a patient who have established cardiovascular disease.
There's one last question. It is how should we screen for and manage renal complication in in patient with
So first
type
and
2
foremost, to
diabetes.
confirm that it is diabetes renal disease. There is a possibility a diabetic renal patient may have some other non-diabetic renal problem also. That's number one. If there is no albumin secretion, no albumin excretion or fundus, is absolutely normal. But once these are confirmed, then these patients should be given the SGLT2 inhibitor because further progression can be decreased. The findranon is other molecule. Albuminuria will be decreased also by using that patient that molecule, and intensive control of diabetes, what we can do.
Thank you, sir. That's all from our audience, sir. And before
Thank you.
concluding, sir, any last remark?
So I will say that in 2024, whatever we learned in last 25 years, now we should use it in our day-to-day clinical practice for a better control of diabetic patients, and intensively we should try to control our diabetic patients. Thank you.
Thank you, sir.